Okay, hello and welcome to this ARMA webinar on the NHS Long Term Plan and Rheumatoid Arthritis, Addressing Unmet Need. ARMA webinars are free to access thanks to the support of our partners, and this webinar has been sponsored by AbbVie, who have had no say in the content of the webinar. My name's Sue Brown, and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA. We're an umbrella body that brings together patient and professional groups who work for better health services for people with musculoskeletal conditions. When we talk about musculoskeletal services in the long-term plan, I think most people automatically think about orthopedics. But actually there's a lot in the long-term plan that also has an impact on rheumatology. Anyone who's taken a look at the recent report of the National Early Inflammatory Arthritis Audit will see that although there have been some improvements in the last 5 years, there are still a lot of delays in accessing the right treatment and support. And today we've got 3 speakers who will be talking about what is important in reducing that unmet need for RA patients. But I'm going to start by asking Dr. Gavin Clooney, who is a consultant rheumatologist and metabolic bone physician at Addenbrooke's Hospital, to outline where the NHS Long Term Plan is relevant to rheumatology and to rheumatoid arthritis. Gavin is on the phone, so I am going to just share his slides as we go. So Gavin, I'm just putting your slides up now. Find them. One. Okay, so we've got the first slide up. Okay, Gavin.
My brief was to set the scene of where we are with looking at how rheumatology configures embedded in what will be a 10-year plan. So I'm not quite sure how much people have got to grips with the long-term plan, but I'm going to briefly overview a little bit about it. If we go to the second slide, you'll see the way in which the NHS has posted that online, obviously free to access. Now, if you go to the next slide, we've got to be aware that what we're told about the long-term plan may vary, and I just pulled this off the BBC from January, and this gives a lot of promises in a very succinct way to patients. And the task here is making the long-term plan work for patients and to meet their perception of what they've been told about. So on the next slide, I thought what I'd do just briefly is just go over what the long-term plan means, some challenges of implementation, and then importantly, and the reason for our webinar today, is the implication or the possible implications, if you like, for rheumatological musculoskeletal diseases. And for those of you who are unfamiliar with that, so these are mainly chronic inflammatory diseases or autoimmune diseases that rheumatologists look after. And they're not all chronic diseases, but a lot of them are. And so this speaks particularly to the way in which healthcare may be configured if we're looking at moving care of chronic disease more to the community from hospital-based care. On to the next slide. So if we look through the hype, perhaps, at what the long-term plan means, we can see that it's building on the 5-year forward view and the formation of STPs. There's a strong focus on prevention and health inequalities. And there's funding uplift, which is configured towards primary care, as you know. And the plan states that this will support integrated care systems, building on STP configurations and primary care networks. Now, throughout this presentation, what I've done is, in italics, put our interpretation and our opinion really based on what the long-term plan is saying. So if you see italics, we're taking what the NHS has said and we're interpreting it. And I have used the King's Fund and 1 or 2 other commentators in doing this. So we could say here that this leads to nudging care out of the hospital if it's not needed there. And we've already had some dialogue locally, for example, about increasing the amount of elective non-critical care of chronic disease to the community. And this will focus more on providing integrated place-based breadth of healthcare, which is no bad thing, but the thing that we're concerned with certainly is whether we can still provide the same depth of specialism to patients who need this in their chronic diseases moving forward. And I'll come back to that point about why that's important. On the next slide, please, Sue. Another key thing from the long-term plan is clinical priorities, and we look at the top bullet point there. We have the main priorities, or the stated priorities of the long-term plan, but that critically that doesn't involve musculoskeletal or rheumatic musculoskeletal diseases. I've just listed there in purple text some specific KPIs, if you like, some example indicators which people are tasked to meet over the next few years. If we go to the next slide, key part of the long-term plan is improving e-access, if you like, so electronic access and remote and virtual management of patient cases. And these three bullet points just highlight very bold promises that the long-term plan has stated. Some of this becomes relevant for managing chronic disease, particularly the first two bullet points. Rheumatology is a very heavily outpatient-based specialty, so that's where we do the bulk of our work, and that's necessarily so because by doing that and having an active, accessible setup, we can avoid acute and emergency admissions to hospital. So we need to make sure that that is not threatened by the change in healthcare configuration. Go to the next slide, and the Health Foundation has raised some issues here on how the long-term plan will result in allocation of funding. For example, there's quite a sizable uplift of funding that will go to primary and community care, but it's quite likely that this will be at a significant expense of not providing the uplift which has been historic for hospital care. And switching demand from out-of-hospital care will reduce pressure on the hospital, but we're not quite sure, and there's an unknown here of how the transition will actually impact care. To my knowledge, and I think to the knowledge of the Health Foundation, when they commented here, there was no pilot mapping of switching funds to pilot that. On the next slide is another key challenge, and that's workforce. And so again, with funding diverting to primary care, the workforce will need to be facilitated. So, and this may well be at the expense of hospital staff as well. And this will, I think, and you'll see my comments there in italic, this will be quite a critical thing, and I think this will be one of the headlines for hospital failures in the foreseeable future. Because if there are blocks to us improving our workforce in hospital at the expense of providing more workforce in the community, then we will see it pretty soon. On the next slide, there are a few other things listed on the top as well. Capital spending. There's little mention of capital spending in the long-term plan. There is a big omission about social care spending, and you'll see the two graphs I put here. The one on the bottom left is how deprivation changes with age and comorbidity. And on the right is quite an interesting analysis of what the BBC put out about how social care funding has reduced over the last 7-8 years, and how the excess has been made up in healthcare funding. And this will be interesting to see how this changes over the next few years as to whether the excess healthcare funding is still going to supplement the reduction in social care funding, and indeed where that funding will go, to primary care or secondary care or both. Multimorbidity is something which isn't mentioned in the long-term plan as well, but we're all seeing this. Doctors at the front line are seeing patients who are more old, complex conditions, and more of them. And managing that, if you manage one condition, then you have to take notice of the other conditions. And we're particularly in the front line with this with rheumatology because of the drug therapies that we use. If you go to the next slide, the last bit of my talk, this is all about the implication as we see it for patients with chronic rheumatic musculoskeletal diseases, and the abbreviation here is RMDs. And these are mainly speculations, but from my reading of the LTP and its commentary so far. So more care will be centralized within PCNs, and we will see the value of this generally. But there will be continued pressure for specialist care, and I think this will probably lead to more virtual care, so things like rolling out more of advice and guidance from specialists, more telephone-based consultations. And I think, and I suspect, that we're not in the front line of priority here. Rheumatology and chronic disease will change, and I think this will be on the coattails of changes regarding IT, driven by primary care network reconfiguration and ICSs. But I think there probably will be a continued struggle to implement care pathways without direct commissioning, and this is really a challenge to integrated care systems. At the moment, we're looking a lot at how patients get to specialists, to rheumatology specialists, at the point of diagnosis. And I think we increasingly will be looking at the point at which people are discharged back to primary care, back to community care once the diagnosis has been made. There will be, I think, greater facilitation to provide prevention, self and peer-based disease management, including the third sector, sort of care deliverable by all, and we're going to talk to that a little later in the presentations, I think, and focus on that. If you go to the next slide, this just illustrates where we are with early referrals. So people with rheumatoid arthritis, spondyloarthritis, psoriasis arthritis, all these chronic arthritis conditions require early diagnosis and early treatment to reduce the morbidity associated with that. So if you look at the national audit statistics here, standard 1 is referral to a rheumatologist within 3 days, and nationally the statistic is 41% of patients do that. But if you look at the funnel plot, there's a huge variation across England and Wales as to how that performance plays out. On the next slide, again, this speaks to early diagnosis, and these are American data, but they have been validated under a number of healthcare systems in Europe. And this is the time to diagnosis of ankylosing spondylitis, spondyloarthritis. And really, the yellow and blue should go straight up from 0 so that you diagnose 100% of people at the time they present with their disease. But you don't, and sadly these data are very similar to what's been happening for the last 20, 30, 40 years. There are studies going right back that show this, that there is a delay in diagnosis, and interestingly this seems to be worse in women compared with men. We don't have time to discuss that further now, but it's an interesting point which has received topical airplay recently on the radio. If you go to the next slide, I think you could view there's a possible cliff edge of chronic disease care. So even if we get patients to specialists, diagnosed quickly, treated quickly, on the right drug therapy, what then? Do they remain follow-up patients under specialist care or get discharged to primary care? And if they do, then how do we ensure ongoing specialist care? And the thing is that we're getting more tools to manage patients much better now. We're getting better drugs. We can target therapies more specifically for rheumatoid arthritis and other arthritis conditions. The thresholds for the changing of these drugs is changing frequently, patient demand is high, and we're on the cusp of the onset of personalised therapy design. So all this leads to quite complex specialist care, and the challenge is going to be to provide this as we're changing a different way of configuring healthcare, or more in community situations and with primary care. So I'm going to leave it there. I've just summarized on the last slide 3 things which I just wanted to leave with people. So the LTP priorities, it says certain healthcare domains and aims to create and enhance frameworks of care delivery in the community. And we all understand the need for that. But I think it will induce nudge-like changes in healthcare delivery to reduce the cost of healthcare out of hospital. The major challenges ahead to avoid backward steps, I think, into the management of rheumatoid arthritis, given that specialism may be moved out more than is intended. However, the bottom bullet point, I think, boils things down to how to try to prioritize where we are with rheumatoid arthritis care in the community. So if we compile robust data on delay in diagnosis and discrepancy in outcomes, and we highlight these real-world data to PCNs and commissioners, then I think we can enhance the visibility of these conditions and the need for prioritizing care. And so that would be my 1 bullet point answer or plan to try and hoist the chronic rheumatic disease care into the priority arena. Okay, I'm going to finish there, Sue. Thank you very much.
Thank you very much, Gavin. I'm just going to stop sharing these slides and introduce Dr. James Galloway, who is a clinical lecturer at King's College London and honorary consultant in rheumatology at King's College Hospital, who's going to pick up on one of the points that Gavin was mentioning there about the improving therapies for rheumatoid arthritis and the importance of early access. James.
Thank you very much. And can I just confirm you see my slides okay?
Yes.
So I'm going to particularly talk about access to therapy early on with a focus on rheumatoid arthritis. I think the treatment paradigm for rheumatoid arthritis has evolved substantially over the last few decades, but the current concept about how we treat, and I'm saying rheumatoid, it's true for many other of our inflammatory autoimmune musculoskeletal diseases as well, that we have an early on in the treatment course, a window where we recognize we need to be rapid in getting people onto medication, often using combinations of medication alongside corticosteroids often, with a move over time to become, we get people onto established maintenance therapy with often slightly fewer drugs, less corticosteroids, but sometimes a switch to advanced therapies such as biologic therapies or Janus kinase inhibitors, which you could also infer that as being high cost therapies. And if you look at what those drugs might be, when I talk about biologics or Janus kinase, this is what has massively changed in rheumatology. And I think if you were to rewind the clock, it was 1999, the first license in the US for TNF inhibitors. 2001, they got NICE approval in the UK. And that was for initially just a couple of TNF inhibitors. By 2005, we started to see other drugs that weren't TNF inhibitors, but different targets had appeared onto the market. And actually, probably about a decade ago, we started to see this term remission appearing in conversation around rheumatology as an achievable option. And by 2019, we've got 5 different anti-TNF drugs. We've got a whole host of other drugs that act on different parts of the immune pathway. And I think this is reflected in terms of what we see in hospital. I remember training in an era where in the 1990s, we had inpatient beds where there would be a 40-bed ward with people with rheumatoid arthritis in hospital. And in 2019, I don't have any inpatients with rheumatoid arthritis anymore. It has transitioned from being a specialty that was quite reliant upon inpatient beds to one that is now managed in outpatients. And this is a graph just showing the number of bed days. This is from hospital episode statistics data, showing the number of bed days attributable to rheumatoid in the UK over a sort of 15-year period, showing this dramatic decline. And I think this is a reflection of several things. I think it's in key part is a reflection of this recognition that if we get people in early and get them onto treatment, they have better long-term outcomes, but also access to these higher costs, the targeted therapies. And just on that point about treating early, and I'm not going to show too many slides sort of about research outcomes, but this was one that this is a slide that's looking at data from a paper published by someone called Desiree van der Heijden from a paper in 1992. And what she showed was that the speed of change of damage differs during the disease course. So she looked over the first 3 years of disease. And if you're looking at the graph on the right, basically the speed of progression, the steeper the graph, the more rapid things appear to be progressing, measured in erosions. And so TOTE is about a measure of visible damage to within the joint on a radiograph, and the pace of change appears to be greatest in the first year and then starts to slow. This is not the only study to have shown this. There's been many studies that have shown and that it looks like early on in the disease course with rheumatoid arthritis, there is this period where the disease advances more rapidly, and if we can intervene then, we have an opportunity to make a substantial difference to long-term outcomes. There's a challenge here, though, and I think a very realistic one related to cost. And this is highlighted in the guidelines we have. We have two sets of guidelines, both from NICE. One set around the disease, saying how we should manage the disease in general terms, without specific information about named drugs, but just the general concept, which talks about targeting a state of low disease activity or remission. And then in a parallel to that, we have guidelines also from NICE about which drugs we can use and when. And in the NICE guidelines, those reserve access to high-cost drugs only for those people with the most severe form of the disease. And so these two guidelines are slightly in contrast to each other, one recommending we target low disease activity and the other saying you can only resort to what we would see as some of our best drugs in the more extreme cases. And having challenged that, actually, it's for very good reasons. It's because the cost of these drugs is phenomenal. In 2007 to 8, we saw biologics. By those, I mean, for example, the TNF inhibitors. They accounted for 2.8% of the NHS drugs budget. There's huge. There's 300 million pounds being spent in a year on these drugs. In 2016 to 17, that had gone from 2.8% to 7.4%. To over $1 billion being spent on these drugs. So the cost of the drugs for autoimmune disease, and I should say, that although I've said it in the top line here, RA, this is actually the cost of drugs across the NHS, so not just being used for RA. I think these drugs are used for other diseases, but inflammatory musculoskeletal diseases account for the bulk of prescribing. They are an enormous cost to healthcare services. And we're seeing these drugs becoming, in terms of the available options, much more numerous, having been initially just a few TNF inhibitors in 2001 to now a whole host of different biologics which are injectable, to also small molecule tablets such as JAK inhibitors. And importantly, we're seeing several of these drugs starting to come off their patent, and then with lower cost versions becoming available on the market. So with that as a background, I'm going to say a couple of things about the National Arthritis Audit, the National Early Arthritis Audit that Gavin has already alluded to. This had the first annual report published in, so the report actually covers May 2018 to May 2019, although the report was published just a few weeks ago. And it was an astonishing effort from the rheumatology community. Rheumatologists across the country collected data on over 20,000 people, nearly 21,000 people, of whom just over 7,000 actually had inflammatory arthritis, rheumatoid arthritis being the most common type, but also included people with diseases such as psoriatic arthritis. And of those, as Gavin said, 41% were referred by their GP within the NICE recommended standard. Interestingly, in secondary care, we did about the same. So after receiving a referral in secondary care, 38% were then seen within 3 weeks in secondary care. The recommendation is that we should be seeing everyone within 3 weeks. Whilst you might look at that and feel despondent about that number, and I have no doubt there is enormous room to improve this. This is better than when this was previously audited in 2014 and 2015. And I think this was the statement, and I like this slide. It was from Ali Rivet, who's the chief executive of the British Society of Rheumatology, just highlighting that prompt diagnosis is crucial in inflammatory arthritis, and it does make the distinction between people who will go on to develop long-term damage and remission. But perhaps even more important than prompt diagnosis is prompt treatment initiation. And the left-hand column here is how many people started on a disease-modifying drug, so started on specific treatment for rheumatoid arthritis within 6 weeks of the hospital receiving the referral. And that number's better. That's over half of people, 54%. Again, there's still a substantial room to improve, although what isn't shown on this slide is if you were to contrast this number with the number from 2014 and 2015, this is already an improvement. And actually, if you look within the year's data, from May 2018 through to May 2019, there is a visible improvement over time already in the data, which is described in the audit. I'm not going to talk about the other aspects of the audit in detail, other than to say that having given some slightly negative measures, that there is an enormous amount of evidence from the audit that there is fantastic rheumatology services out there, particularly in terms of access for example, patient information, and this has been in large part to support through patient organisations such as NRAS, which we're going to hear from Elsa in a minute. And this is one of the other striking headlines from the audit, which is that it's important to say how we do in terms of the processes. And what I've described to you so far were processes. How many people were seen quickly, how many people were treated quickly. But maybe the most important metric is how people come on in terms of clinical outcomes. So by 3 months, we saw 37% of people who were diagnosed with rheumatoid in a state of disease remission. And that is a really good number. If you look in clinical trials of new drugs, that's the sort of number that you see in the clinical trials. So this is a fantastic piece of information. This is evidence that the rheumatology community is working very hard. Again, I'm sure there is more to do, but this is a good sign. So I think things are going to change in the coming years, because I think we are starting to see rapid changes in the cost of the drugs we've got access to. We're seeing that the drugs we're using are getting better. Part of that is about the drugs have higher efficacy, but also the strategies, the way we use them, the way we use combinations, and the fact we're recognizing we get people in early. And the treatments we're using, I think, have fantastic safety profiles. And one of the crucial things about that is that slide I showed you about hospital bed days, the number of people who are getting admitted to hospital with rheumatoid arthritis is plummeting, because there is no doubt that of all the drugs we've got today, their safety profile is far, far better than the safety of having uncontrolled, untreated rheumatoid arthritis over time. This is my final slide, which is, I think, just to say, well, there are still some questions remaining, and I think we have ongoing questions about whether, with our recognition about the importance of disease control, we are being swift enough. The NICE guidelines around what our thresholds are for treating. So DAS is the Rheumatoid Arthritis Disease Activity Score. That's the threshold that we currently benchmark when we can start the targeted therapy, the high-cost therapies. And I think we question whether that is the right threshold. But I think one of the greatest challenges we have, and Gavin also alluded to this, is how do we make sure that when we see people, spot them early on in their symptoms and start them on treatment, we get the right treatment for the right person first time around. This approach to what we want to aspire to, of personalised medicine. And I think we still have a way to learn now, because at the moment we do have a slightly one-size-fits-all approach to treating people early, and there are probably some people who need early treatment and aggressive early treatment much more than others. I will, Sue, hand back to you at this point.
Thank you very much, James. There was some quite encouraging messages in there as to balance some of the not so encouraging ones, and it's good to hear that things are improving. Our final speaker is Ailsa Bosworth, who is the National Patient Champion at the National Rheumatoid Arthritis Society, NRAS. And one of the things that ARMA has been championing for a long time is the importance to people who've got any long-term condition, really, of peer support. And so Ailsa's going to talk about peer support in the context of RA and how NRAS can help and what sorts of things can be provided by the third sector and patient organisations. Ailsa.
Thank you very much, Sue. I'm just going to share my slides now. Hopefully that will, yep, great.
Yes. So we just do from the beginning.
Yeah. Okay, so I've been asked to talk about the importance of self-management, integrated services, and what patient groups have to offer. And in the context of the long-term plan, I think that really the title of my presentation relates to subjects that are dear to my heart and hugely important to NRAS and to patients. And there's nothing, as we've heard from Gavin, that's specific in the long-term plan on RA or inflammatory arthritis, sadly, but it does talk about better self-management and mental health support for those affected by chronic conditions. And this is welcome, but I do have real concerns about how far these issues are going to be prioritized in delivering the plan. So my presentation is going to focus on the importance of supported self-management, what it actually is, what patient groups have to offer in this respect, and in particular, what NRAS can do. So what you see here on my first slide are the 6 domains identified as key priorities by NHS England's universal personalised care. And implementing the comprehensive model is the delivery plan for personalised care in the NHS. So we don't really have time in this talk to go through all of these bullets, but I did want to touch briefly on shared decision making before going on to talk about supported self-management, because I think we still have a long way to go in regard to shared decision making and making it universally practiced. In my view, it's less about offering specific tools and grids and similar resources for patients to follow, but more about having a different kind of conversation with your consultant and your healthcare team. And it needs to take into account things like how engaged a person is in their own healthcare, their level of health literacy, for example, their cultural beliefs, whether English is their first language, and similar issues. NHS England have been piloting patient activation measurement to determine patient engagement. And whilst I think this is a very useful thing to do, I think its universal rollout and use, I suspect, will be hampered by a lack of infrastructure in how to then interpret the results and deal with them. And I believe its currently relatively high licensing cost will, I suspect, need to be restructured if it is going to be rolled out more widely. Choice, I think, for patients and for clinicians is becoming less and less possible in the era of biosimilars, as James has talked about, and switching programs. And clinical autonomy is also diminishing as a consequence, neither of which are we particularly happy about. So, supported self-management, what is it? Well, there are a variety of definitions of self-management, and this one comes from work by Julie Barlow and colleagues. And it's perhaps a little academic, but in practice, self-management is about being able to manage your RA and your treatments and your day-to-day life in the best possible and most realistic way to suit your own lifestyle. It's not about ignoring or denying a health condition, and nor is it also about allowing that condition to dominate your life as sometimes it can do. Rather, it offers a more constructive way of living that's been shown to improve long-term outcomes. And what this means in practice is that by having a helpful understanding of your disease, being able to recognize and manage the emotional impact, being able to, and willing, more importantly, to make adaptations to your lifestyle and the way you approach doing things, you can take back control and get back into the driving seat again. But the important part to remember about this is that people need to be supported to achieve all this. It's not something that they can do in isolation. So when a person is diagnosed with inflammatory arthritis, on average, they're likely to spend no more than a few hours a year in the presence of a specialised healthcare professional. And in the remaining time, they're going to be effectively self-managing and dealing with their condition on their own. And that means dealing with not only the practical things, the physical, the psychological and emotional impacts of the condition, but also other things like work, family relationships, and so on, whether or not you might be supported by family and friends. And we know that the ability to self-manage well contributes to better long-term health outcomes, and that really is why it's so important. Common mental health conditions in particular represent an important and often poorly addressed comorbidity in inflammatory arthritis, and they have direct relevance to disease outcomes. More specifically, poor emotional and mental health has been associated with poor coping strategies and poor self-efficacy with a bidirectional effect. From our national patient surveys in recent years, anxiety and depression are often two of the top comorbidities reported by patients themselves. And so addressing mental health as well as physical health is therefore crucial and more likely to be achieved if more holistic approaches to patient care are adopted. It's long been acknowledged that the challenges faced by people diagnosed with long-term health conditions can be made easier, and the response is more productive if appropriate support and guidance is signposted and provided at key points in the post-diagnostic treatment pathway. And although a number of educational materials and resources may be available for self-management, and I'm going to come on to talk about what we can provide, really, these are often underused and not always incorporated in the routine care of patients with inflammatory arthritis. We know that time pressures, underlying health service infrastructures, and also a lack of knowledge by health professionals of what is available and how best to address self-management aspects of care are recognised obstacles to providing the necessary support in a sensitive and patient-centred way. James has talked about the NICE guidelines and the NICE quality standards that are being audited with rheumatology teams across England and Wales at the moment. And quality standard 4 is the quality standard that talks about providing education and self-management resources for patients within a month of diagnosis. I sometimes think that a month of diagnosis is actually not always the right time space for everybody because it's not a one-size-fits-all. But that's what the quality standard says. So most of the patient education in rheumatology teams is done by the specialist nurses. Usually within a week or two of diagnosis, a patient will have an educational session with their nurse. And much of it necessitates providing information and education about the medication that's being provided to that individual, with methotrexate in RA being the anchor drug. Nurses have a lot of things on their agenda which they have to do, such as blood monitoring, disease activity score measurement, ensuring the patient knows how and when to take their drugs and what common side effects are, and how to contact the team. And often the time and the sheer burden of work means that the things that the patient may be very concerned about and want to raise don't get raised. And then how best to direct that individual to supported self-management resources may not always get done, or be done in a way which takes into account things like social support, level of education, cultural beliefs, and perhaps unhelpful health beliefs of that individual themselves. But this is where NRAS can really help support both the healthcare teams and the patients. So I want to just start off by talking a little bit about our resources and particularly our Right Start service. This is a new service that we launched in spring this year. And Right Start supports people newly diagnosed with RA to understand their diagnosis, how it's likely to affect them, and getting the right support early on can really help people to make adjustments to their behavior, their lifestyle, and their health beliefs, and understand why self-management is important and how to make those important first steps to managing their disease effectively. Health professionals can make a consented online referral direct to NRAS. It's really quick and easy for health professionals to do. And NRAS then takes control and contacts the patient and arranges for a call with our helpline team, which can be up to an hour long. Following that initial call, we provide a completely tailored pack of information, which is a combination of written material that's sent by post, plus links to our online peer support community, maybe a selection of links to some of our videos and other web-based resources. And then they can have also a peer support call by one of our trained volunteers. And if they need it or they want it, another follow-up call again with both the helpline and that peer support. If desired, it can also be arranged for them to have ongoing support from our helpline team. But what we've found so far from experience is that usually it's that first important call that really is the one that sets them on the path to better self-management. And we've now got 20 hospitals referring newly diagnosed patients to us, and we're getting great results and good feedback. And I just wanted to share with you some of the feedback that we've had from people. The top left comment was actually a professional pharmacist who was diagnosed with RA and reacted really quite strongly to the in a negative way to being put onto methotrexate. The other two comments are comments recorded by our helpline team in the notes after talking to specific patients. Hopefully you've got the gist of that. So the kind of resources that we offer, bearing in mind that, as I said, self-management is not a one-size-fits-all. We provide a whole range of things in different formats to suit people. You know, some people like to speak to someone, some people like to go online and just look at what people are saying, some people like to get written information or contact us by email. Whatever the way is that people want to employ, we can usually provide that. And these booklets are freely supplied to all hospital teams across the UK. We've got over 150 videos on our YouTube channel on all aspects of living with RA and the treatment of RA. We've got, as you can see on the left here, videos specifically about methotrexate, how to take it, pregnancy, breastfeeding. There are a whole galaxy of subjects that people need help and information on. We have an online cardiovascular risk assessment program that enables people to understand more about why we are at greater risk of getting cardiovascular disease and more likely to die, in fact, of cardiovascular disease early. And so learning about how you can minimize your own risks on the things that you can control, like your weight and your eating habits and so on, really important for patients to understand about that. So Love Your Heart is an important tool giving people that kind of information. We've got animated videos about biosimilars to help people to understand what biosimilars are and what the switching programs are that are going on at the moment. We've got lifestyle videos like Behind the Smile, where people can really relate to the story that happens in the video. We have a Facebook page, and we've got lots of patient stories on there as well. We've also got probably the largest global RA online peer support community in the world. As you can see here, we've got over 26,000 people using this community, primarily from the UK, but we also have a lot of people joining from the States, from Canada, Australia, New Zealand, and Europe. And in fact, last year, in the last 12 months, we've had over 1.5 million people from around the world looking at this. So peer support is becoming a very, very important part of the whole self-management resources. And it's a platform that, importantly, we moderate. One of our team reads every single new post that goes onto the forum on a daily basis to keep it safe. And to ensure that the right information is given and to step in and provide information where it's needed. We've got many more resources. We run webinars very similar to the one we're having now on different aspects. In fact, James has been one of our fantastic presenters, and we typically get anything between 300 and 500 people signing up for these webinars on a whole range of different subjects that are then available for people to watch after the event if they can't join to watch it live. We have events for patients that we hold in cities around the UK if they want to come along to a face-to-face event and meet with health professionals and hear about subjects that are important to patients. We develop annual reports following major UK-wide surveys, and you see here two recent ones, Work Matters and Emotional Health and Wellbeing Matters. And these are reports that can be used by health professionals. They're all professionally produced. They have some academic rigor about them. We partner usually with universities to deliver these, and the statistics are usually very helpful to health professionals to understand the latest situation in regard to whichever subject the report is on. And we have our peer support. Not only do we have a 24-hour community online, but we also have individual telephone peer support volunteers who are trained to provide the kind of one-to-one help on the phone that people need. We have a number of apps that we partner with software development companies to produce, and we've got 3. I'm not going to go into the details of these, but they're all available on iPhone and Android, can be downloaded directly from our website, and help people who want to use an app to help them track their symptoms and interact with their healthcare team. We're also developing resources for those hard to reach populations, and here we've got a whole range of resources on our website in Hindi, primarily in video format for the South Asian population in the UK, because I'm very conscious of the fact that patient organisations like NRAS tend to be reaching out to people who are engaged in their healthcare and who are looking for us or looking for support. And we're very conscious of the fact that there are many people out there who actually need our support, but wouldn't necessarily look for us or reach out to us. Haven't mentioned anything about integrated services, which was part of the title of my talk, but I just wanted to mention a few bullet points here. One of the things that we found from our own research and also talking to rheumatology teams around the country, integration between primary and secondary care does vary hugely. I was in a unit in the north, a community-based unit in the north a couple of weeks ago, and all of the GP prescribing and DMARD monitoring is done by that community unit because the GPs in the area will not do it. And, you know, so this is a situation that I think would be much more helpful to patients if all GPs were to undertake prescribing of DMARDs and monitoring services, because going into a hospital unit to get your blood done is pretty inconvenient from a patient's perspective, with all the parking problems and so on that we experience when we go to the acute hospital. I think GPs can be very helpful in the annual holistic review that is required and mandated in the NICE quality standards for RA patients. It should be organised by the rheumatology team, but it certainly could involve GPs more widely than it currently does, particularly around things like cardiovascular risk assessment. And I think it would improve patient care and safety if primary and secondary care could automatically share patient records and share care more effectively. But I'm going to stop now so Sue can take control, and I think we're going to have some time for some questions. Thank you.
Thank you very much, Elsa. And yes, so we have a little bit of time left for questions. We don't actually have any questions in the Q&A box at the moment. Don't be shy. I know there's lots of people listening in. Please do type any questions you might have for any of the presenters into the Q&A box. But while we wait to see if any of the participants have any questions, I just wanted to ask all of our presenters. So James talked a bit about the way that the audit is showing that there is improvement happening. I think we're probably way off where we want to be, but there's improvements happening, and you said there's even improvements been happening in the year that the audit's been being carried out. Have you got any thoughts on what might help to push things in the right direction? We've got all sorts of people registered for this webinar: commissioners, service transformation leads, physios, nurses, GPs, all sorts of people. What would help to push things in the right direction, does anybody think?
So, well, thank you. Can you hear me okay?
Yeah.
I think one of the real challenges in healthcare and in terms of improvement in healthcare is about ensuring people know about performance and understanding the variations. And one of the most important things, I think, is about how we get the information, like, for example, from the national audit and from other large-scale projects that collect continuous measures over time and then show people this is how we're doing. And then commissioners, because when you look at performance variation, the reasons for performance variation are complex, but a major one is often resource. And so commissioners need to look at the information that's provided by NEA. And I think this is the first time we've seen in a rheumatic musculoskeletal disease an HQIP funded audit that is really putting out into the public domain information about variation in care. And to be able to recognise that and then say, well, this is where we need to support departments and work with them to improve.
Anyone else got any thoughts? That was me being muted.
I think also I agree with James, but I think also there is a whole piece around public awareness. Because we know that one of the biggest delays in getting people to a GP in the first place is the fact that the symptoms they're experiencing aren't recognised by that individual as being something serious that needs urgent attention. So that's the first of three delays. The second delay is when the GP doesn't recognise the early signs and symptoms, because it, to be fair to GPs, it does present in many different ways, and could be down to other things, and so sometimes the GP will delay referring because they'll try some anti-inflammatories or something like that and send the patient away to see how things go. And then the third delay, although that things are getting better, as James has explained, is getting then into the secondary care system and getting started on disease modifying drugs. So I think that the public awareness is an area that certainly we and other third sector organisations do as much as we can within the bounds of our resources to raise awareness. But part of the problem with something like rheumatoid is that people hear the word arthritis and automatically assume you're talking about something old people get that's not terribly serious, and we all get a bit of it as we get older and not a lot to do about it. So it's changing that perception and getting across the fact that there are a group of inflammatory autoimmune conditions that actually are not about wear and tear that we all get as we get older, that are serious, complex, and need urgent attention. And I'm a classic example of somebody who did not get the right care when I was diagnosed nearly 40 years ago, and as a consequence I've had 20 surgeries so far, probably with more to come, and I'm an expensive animal. If I had had the right treatment right from word go, which wasn't possible then, incidentally, because we didn't have the treatments that we have now, but things could have been very different for me.
Okay, so we've got some questions coming in now. I'm going to start with this one, which was particularly directed at Ailsa in relation to what you said about supported self-management. You didn't mention the role of AHPs in supported self-management. Do you have any thoughts on that? And also, are you getting referrals to NRAS from AHPs?
Yes, we are. They primarily are coming initially in the newly diagnosed patients as part of Right Start service. They're coming from the nurses rather than the practitioners such as physios, OTs, podiatrists, and so on. But I'm sure that those practitioners will become more a part of Right Start as Right Start becomes more established in rheumatology teams. And of course, nurses, allied health professionals, the whole team has a role to play in supporting self-management. But as I explained in the presentation, the lack of time, the number of patients, and the increasing technical aspects that nurses have to and AHPs have to take care of today mean that the kind of time that you need to talk somebody through their fears and concerns, particularly at crisis points in their journey, such as newly diagnosed, or when they're starting on a new treatment, or they're facing surgery, or they want to have a child, or something of that nature. You know, they don't have the time, and they don't have the resources that, you know, I've shown you some of the resources that we have. It's so easy for health professionals when talking about some of these subjects to say, listen, go onto the NRAS website. They've got a fantastic foot health section, whole series of videos about looking after your feet because this particular patient has got a foot problem. You know, there's all sorts of things that can be done, but I think often in the hurly-burly of a routine outpatient clinic, these things are forgotten, and they're not as used as our resources are not as used by health professionals as perhaps they could be. But certainly, of course, you know, multidisciplinary team members, hugely important for patient care.
And I think if for the AHPs who are joining us today, perhaps you could talk to your relevant national organisation and just see if there's anything that can be done to make AHPs more aware of the resources that NRAS and other patient groups have to offer, because I do think it's really key. We're coming towards the end. Here's a bit of a biggie. Hopefully it won't take too long to answer, which is, what discussions have any of the speakers had with NHS England on the issues that you've raised, and are they acknowledging the challenges? Has anybody got any thoughts or views on that?
Well, I can say I haven't talked to NHS England, but what I have done is initiated a dialogue with our STP, which in Cambridgeshire, for example, was formed quite quickly, and with its, it was hit the ground running really, because it was formed from just 2 CCGs. Now, what Cambridgeshire have done is they have a single point of access practitioner running an MSK service, which will triage people in theory to a rheumatologist if they need. Now, one of my concerns, which I highlighted a bit in the talk, is continually pressing that pinch point to make sure that the right people are in the right places to make triage decisions. And we've sort of discovered that that's not the case. There's quite a high turnover of people who work as physios mainly in this role. But I think our role as specialists probably has to be a recurring educational support role, so that those people know exactly when a rheumatoid arthritis patient comes along, know exactly when an ankylosing spondylitis back pain person comes along. Because I think just giving someone a template, a paper case, and saying, right, just send us all the people who look like that, is not going to work. And we've all talked about the importance of early diagnosis, but I think unless we configure some formality into that single point of access, we're going to continually miss to see people as early as we should.
Can I just pick up on what Gavin has just said? I totally agree. And one of the things that I think is to be welcomed in primary care are the first point practitioners, which are now increasing numbers coming into primary care. And these are physios. a patient coming into a GP practice could be seen by one of those physios rather than the GP. And if those physios don't get the right training to identify the red flags of inflammatory and rheumatoid arthritis, then we could be delaying referral into secondary care again. Right. So these are things that are to be welcomed, but there are concerns nevertheless.
And I think both those two comments are quite a good place to end, because whilst NHS England is setting the long-term plan, is supporting various programmes, ultimately the changes happen locally. And I think that's something that everyone on this webinar can do, is to engage locally to make sure that, for instance, the first contact practitioners that are being recruited do meet the national competencies, which will include understanding and identifying the red flags, that the pathways are designed so that there's good connection between secondary care and primary care, and all of those things that we know are needed locally in order for all of this that we've been talking about to happen, in order for the improvements to continue. So we have run out of time now, but I'd like to thank you all for joining the webinar, and particularly thanks to all our three speakers for their helpful presentations. I hope you all found this useful. The recording will be available online, and you will all be sent a link to that shortly. So please do share the recording with anyone you think might find it useful. Thank you very much.
Thank you.
Thank you.
Thank you.